Thank
Your
you.
MD, I need the introductory slide. Hello. Yeah. He is MD, Endocrine and Metabolism, member ACE, Assistant Professor and Head, Department of Endocrinology, Mymensingh Medical College and Hospital, Bangladesh. And his specialty is endocrine and metabolism. He has major field of interest, in particular in type 2 diabetes, vitamin D, PCOS, etc. Academic qualification, as I already said, he is an MD from Bangabandhu Sheikh Mujib Medical University. He has numerous affiliations like ACP, Diabetes in Asia Study Group, Bangladesh Endocrine Society Association, ACE of Bangladesh, and undergone research activity and been a co-investigator in numerous papers, various presentations, international, national conference, seminars, etc. And his publications around 45. Thank you for joining us, Dr. Kamrul, and it's all yours. Please go ahead.
Thank you, sir, for those kind words for me. I want to thank the Cardiabcon 2021 committee for inviting me to speak here. And I am also think myself fortunate enough to talk in such a prestigious occasion named after the name Professor Sharita Bajaj, who is not only an endocrinologist famous in India, but also I think is a leading endocrinologist in this part of the world, especially in the Southeast. I am going to directly to my topic. My today's presentation is the metabolic derangements in polycystic ovary syndrome. This is my today's agenda. We'll talk a little on the overview of diagnostic criteria and pathophysiology of PCOS, and we'll look on the traditional and non-traditional risk factors in PCOS. And I will share some data of PCOS that is generated by our group in Bangladesh. And I will highlight on the guidelines for screening and managing cardiovascular risk factors in PCOS. PCOS is not a modern disease. This was has been recognized even in the old literature, even by the Hippocrates in his famous book Disease of Women. And thereafter, the modern description of polycystic ovary syndrome was first made by two legend gynecologists, the Irving Felstein and Michael Leventhal. And their description of 7 women with such a disorder was published in American Journal of Obstetrics and Gynecology in 1935. Thereafter, various diagnostic criteria, as PCOS is a syndromic disease and there is no specific diagnostic test for defining PCOS. So various diagnostic criteria has been proposed by NIH, ROTTERDAM, and American Endocrine Society. But I am not going in detail of this diagnostic criteria, but I want to highlight on the issue that none of these diagnostic criteria address metabolic derangements in PCOS. So I think this is a lacking in the in addressing the nomenclature of polycystic ovary syndrome. Later on, based on this heterogeneity in presentation, various phenotypes of PCOS has been described. Among them, 4 leading phenotypes, that is the phenotype A, phenotype B, and phenotype C. Phenotype D is the mildest form of PCOS that is not associated with hyperandrogenism. If we look back to the pathophysiology of polycystic ovary syndrome, this is a complex disease with interaction of several genes with environmental factors. And the insulin resistance in polycystic ovary syndrome is selective insulin resistance, that is the metabolic resistance of insulin. But these insulin act as a act synergistically with LH to secrete testosterone from the ovaries, and androgen excess in PCOS, the main source is the ovary, and all these will lead to increased gonadotropin releasing hormone pulses and increased LH-FSH ratio, ultimately impaired oocyte development, antral follicular arrest, and there is a polycystic appearance of the ovaries. In short, the pathophysiology of metabolic disturbances in PCOS, this probably starts from visceral adiposity and insulin resistance, which is exacerbated by hyperandrogenemia. And there is a vicious cycle of hyperandrogenemia, hyperinsulinemia, insulin resistance is established. And ultimately, there are elevation of the several markers of cardiovascular risk factors. And ultimately, increased risk of type 2 diabetes mellitus and cardiovascular risk. Now I'm going to discuss the traditional and non-traditional cardiovascular risk factors in PCOS. These are the results of meta-analysis by Lim et al. This has clearly shown that the prevalence of overweight women is increased in PCOS. That is 1.95-fold higher. The prevalence of obesity is 2.77% sevenfold higher in PCOS compared to the normal women having no PCOS, and also the PCOS women have increased risk of central obesity, that is around twofold higher risk of central obesity. This is the recent meta-analysis published in Human Reproduction Update that consisted 23 cohort studies. This has clearly shown that women with PCOS has almost twofold higher risk of hypertension compared to non-PCOS, and they have also almost threefold higher risk of type 2 diabetes mellitus. They have, on an average, they have 7.14 milligram per dl higher total cholesterol, which is statistically significant compared to non-PCOS. But the level of LDL cholesterol in this meta-analysis was found similar in PCOS and non-PCOS, and level of HDL cholesterol was found 2.45 milligram per dl lower in women with PCOS. And the triglyceride level was found almost similar, though other studies have shown the higher triglyceride levels among PCOS women. If we consider the risk of gestational diabetes mellitus, this one is another meta-analysis. This has clearly shown that there is almost threefold higher risk of gestational diabetes mellitus among women who are diagnosed with polycystic ovary syndrome. And there is a ethnicity differences among in the risk of these diabetes and other cardiovascular risk factors. These studies have shown that there is increased risk of almost 3.5 fold higher risk of impaired glucose tolerance among PCOS patients, and also threefold higher risk of type 2 diabetes mellitus. And this study highlights on the differences in ethnicity, and higher risk in all ethnic groups are exacerbated by obesity. And for impaired glucose tolerance, Asian women had 5.2-fold higher risk of having IGT. Americans had 4.4-fold higher risk, and Europeans had 2.6-fold higher risk. The ethnicity-related difference retained its significance for Asia and Europe in BMI-matched subgroup. That is, the risk of IGT in PCOS is not dependent on body mass index. Rather, this is exacerbated by higher BMI. For type 2 diabetes mellitus, Asians have 4.4-fold higher risk, Americans 4.7-fold, and Europe had no difference in the risk of type 2 diabetes mellitus after a sub-analysis of the ethnicity specificity. But this ethnicity-related difference did not retain its significance for Asia, the Americans, and Europe in BMI-matched subgroups. There is also higher progression of glucose intolerance and diabetes mellitus in women with PCOS than who had no PCOS. This is a study. This is a cross-sectional study that had they were followed up over a decade. This has shown that the impaired glucose regulation after the end of follow-up, the PCOS women had higher risk of mean change in the prevalence of impaired glucose regulation, higher risk of diabetes mellitus, and this was significantly marked. The mean changes in the risk of diabetes, prevalence of diabetes and impaired glucose tolerance was marked in women who had higher BMI, that is BMI 23 or more. And the prevalence of hypertension and dyslipidemia, the mean change was also higher in PCOS group in comparison to the control groups. And this study also showed that the age standardized incidence rate was higher in PCOS for diabetes mellitus compared to control, even compared to the local population who are not included in the studies. And this progression to diabetes mellitus was also higher in the people who are either overweight or obese. The progression of glucose intolerance and metabolic cardiometabolism. These studies also have shown that there are significant difference in the progression of over the different phenotypes of polycystic ovary syndrome, and they have demonstrated that phenotype A and B had shown higher occurrence, higher conversion to either diabetes or impaired glucose tolerance after 10 years compared to phenotype D. And important observation by the investigators was that diabetes onset was on an average 10 years earlier among women with PCOS than in women without PCOS. And the risk factors they identified were high waist to hip ratio, elevated triglycerides, and presence of hyperandrogenism. All are associated with progression of type 2 diabetes mellitus in PCOS. If we consider the metabolic syndrome, this is another meta-analysis comprising 72 studies. Though there was high heterogeneity among the included studies, the old estimate of the association between metabolic syndrome and PCOS was significant with an odds ratio of 2.57%. So we can say that PCOS patients have higher risk of metabolic syndrome also. And the prevalence of metabolic syndrome varied according to the definition of metabolic syndrome used in the meta-analysis. We also found another cross-sectional study that was done in 5 countries in 5 centers. This included more than 1,000 polycystic ovarian syndrome patients who were diagnosed according to ROTTERDAM criteria. This has shown that the prevalence of metabolic syndrome was highest among the US Black, 52%, followed by Indians, that is 38.2%. But interesting thing is that the Indian PCOS women had higher prevalence of hypertriglyceridemia, higher prevalence of having fasting blood glucose higher, and lower HDL cholesterol. So the metabolic components, the components of metabolic syndrome was deranged in Indians. I can say that in this subcontinent women. So this is another thing. And if we consider the non-obese PCOS patients, this is another meta-analysis. They have clearly shown that the prevalence of hyperinsulinemia, insulin resistance, impaired glucose tolerance, type 2 diabetes mellitus, high triglyceride, and low HDL. These are all significantly higher in non-obese PCOS patients compared to their non-obese healthy non-PCOS patients. And these meta-analyses have demonstrated that the risk of impaired fasting glucose, pre-diabetes, dyslipidemia, high total cholesterol, and hypertension was almost similar in non-obese PCOS compared to their BMI-matched counterparts. And non-obese PCOS patients also have higher risk of metabolic syndrome, as shown in this meta-analysis. They have almost 2.5-fold higher risk of metabolic syndrome. In subgroup analysis, the authors of this meta-analysis found that whites exhibited increased risk of insulin resistance, impaired glucose tolerance, impaired fasting glucose, type 2 diabetes mellitus, hypertension, and metabolic syndrome. But Asians had no significant metabolic change compared to their non-obese healthy counterparts. So this is another finding. And if we consider the adolescents, patients with polycystic ovarian syndrome, this meta-analysis has shown that the adolescents with PCOS have 5 millimeter mercury higher systolic blood pressure, 3.52 millimeter mercury higher diastolic blood pressure, some lower HDL cholesterol, high triglycerides, high glucose, higher waist circumference, and obviously high risk, around 2.7-fold higher risk of metabolic syndrome. So even in adolescent, the non-adolescent patients with PCOS have higher risk of metabolic syndrome than those who had no polycystic ovarian syndrome. And now I'm going to discuss some non-traditional risk factors that have been measured. These are not done routinely; they are done only on research purposes. Carotid artery intima medial thickness in polycystic ovarian syndrome. We all know that every 1.1 millimeter increase in CIMT has been estimated to increase the risk of myocardial infarction by 15% and the risk of stroke by 18%. This was an observational study. This was a meta-analysis that included more than 1,000 women with PCOS and more than 900 women in the control group. It has clearly shown that the summary mean difference in CIMT among women with PCOS compared with the controls were 0.072 millimeter for highest quality studies, and for good quality studies it is a bit higher, that is 0.84 millimeter. So these patients with PCOS have higher carotid artery intima media thickness, establishing that they have higher risk of myocardial infarction and stroke. This was a coronary artery risk development in young adults women study. that is Cardia study. This was done over a decade, over 2 decades. At the year 20, the PCOS women had uh, higher coronary artery calcification risk compared to their controls, even after adjustment for age, race, education, smoking, menopausal status, BMI, systolic blood pressure, triglyceride, and HOMA-IR. But in those who had isolated oligomenorrhea or isolated hyperandrogenism, the risk of coronary artery calcification was not higher. This indicates that the all components of metabolic syndrome, all components of PCOS that is required to define PCOS increase the risk of uh, coronary calcification, but not not when these manifestations like isolated oligomenorrhea or isolated hyperandrogenism are present separately. Endothelial dysfunction measured using flow-mediated dilation in polycystic ovary syndrome. This is another meta-analysis. This has shown that the flow-mediated dilation is a very well-known non-invasive marker of cardiovascular disease and cardiovascular death also. In this meta-analysis, they found that pooled mean flow-mediated dilation was 3.4% lower in PCOS compared with control. In a sub-analysis of 7 studies, PCOS-mediated reduction in FMD was 4.1%. These 7 studies they conducted as the gold standard or well-conducted studies. In these well-conducted studies, the PCOS-mediated reduction in FMD was 4.1%. And this flow-mediated dilation difference was not influenced by body mass index or race. There are meta-analysis involving the circulating inflammatory markers in polycystic ovary syndrome. This has clearly shown that circulating C-reactive protein was 96% higher in women with polycystic ovary syndrome compared to their controls. And this higher CRP was independent of obesity. This meta-analysis also have found that interleukin-6 and human necrosis factor alpha had no statistically significant difference between the polycystic ovary syndrome and the control women. PCOS is associated with adipokine abnormalities. This meta-analysis has shown the differences in various adipokines levels. Adiponectin level have found to be decreased in patients with PCOS, and there is increased fumarine, increased leptin, resistin, and visfatin also. And no significant changes was observed in the apelin, irisin, momentin, and vasmin. And coagulation and fibrinolytic disturbances also have been found in patients with polycystic ovary syndrome. This is shown that the PCOS, visceral obesity, and NAFLD work together to induce insulin resistance, inflammation, dyslipidemia, and hyperandrogenism, all results in decrease in fibrinolysis and increase in coagulation. This is another meta-analysis. This has been shown that after adjustments for age and body mass index, circulating PI1 activity and fibrinogen levels are higher in PCOS than controls. Lipid profile, blood pressure, and levels of D-dimer, von Willebrand factor, factor 8, tissue plasminogen activator, and inflammatory markers were comparable in the two groups. In multiple linear regression analysis, they found that low sex hormone binding globulin level and high insulin predicted high PI activity, and elevated high sensitive CRP and soluble E-selectin in combination with heart rate predicted the high fibrinogen. Differences in PI1 activity are not significant after adjustments for age, BMI, sex hormone binding globulin, and insulin. So some form of coagulation and fibrinolytic problems are also have been shown in polycystic ovary syndrome. Cardiac dysfunction has also been observed in patients with PCOS. Compared to age and BMI mass control, young PCOS women have higher left ventricular mass index, which is a predictor of cardiovascular disease, mortality, and morbidity. They also have shown to have decreased diastolic filling and decreased left ventricular ejection fraction. And another study also found that late reproductive aged women with polycystic ovary syndrome display impaired cardiac autonomic function manifested as decreased vagal activity. And metabolic status rather than hyperandrogenemia and PCOS per se was the strongest contributing factor for decreased vagal activity. So I'm going back to the previous meta-analysis done by Wecker et al. If we translate all these cardiovascular risk clinically, what will be the results? This meta-analysis has shown that the risk of non-fatal coronary events among women with PCOS is clearly raised 1.78 fold in PCOS. But the risk of non-fatal sorry, the risk of non-fatal coronary events are not statistically raised in patients with PCOS, but the risk of non-fatal cerebrovascular events are statistically higher in patients with PCOS compared to non-PCOS women. And if we compare the composite outcomes for fatal and non-fatal cardiovascular disease as a whole in patients with PCOS and non-PCOS, we found that PCOS women are not at high risk at all. So if we summarize these results of this meta-analysis by Waker et al., we found that women with PCOS had increased risk of hypertension, type 2 diabetes, a higher serum level of total cholesterol and lower HDL cholesterol, and increased risk of non-fatal cerebrovascular disease events. But no difference were found for LDL cholesterol, triglyceride, and coronary disease events. They also have commented that conclusion concerning the fatal outcome was not done due to the paucity of the mortality data. This is another meta-analysis done by Zhang et al. This included 10 cohort studies, and there was a large number of samples. The higher pooled risk of cardiovascular events was higher in PCOS patients, and PCOS group has higher risk of myocardial infarction, ischemic heart disease, and stroke. There was no significant difference in overall mortality and cardiovascular related death. So there is a gap between the baseline knowledge, that is the higher risk of increased cardiovascular risk, and also the outcome. The metabolic risk are not the same across the phenotypes. We know the hyperandrogenic phenotypes have higher risk of metabolic syndrome and also other higher metabolic risk markers compared to the normal androgenic phenotype D. Now I am going to share some data, some small cross-sectional studies done in our setting that we have conducted a pan-Bangladesh study. The frequency of overweight and obese was 84%, central obesity was 84.6%, and acanthosis nigricans was almost present in all. And the frequency of pre-hypertension or hypertension was around 35%. The abnormal glucose tolerance, that is pre-diabetes or diabetes, was observed in 34.1%, and almost all, that is 93%, had dyslipidemia. And metabolic syndrome, according to IDF criteria, 57% had metabolic syndrome. So our findings are a bit higher compared to the Western countries and compared to the some studies that is done in India. And we observed a higher frequency of metabolic syndrome in the hyperandrogenic phenotypes, though the intergroup difference among the phenotypes was not statistically significant. And we've observed similar frequencies of overweight and obesity, central obesity, pre-hypertension, hypertension, dysglycemia, and dyslipidemia among the 4 phenotypes. We also have some data among for adolescent PCOS in our country. They have among them they are around 30% were overweight and 40% were obese. They had 65% of them had abdominal obesity, and 3.4% had hypertension, and 20% had pre-hypertension. The abnormal glucose tolerance among the PCOS adolescents were 24%. That is pretty alarming. And almost all of them, that is 91%, had dyslipidemia. And according to the IDF consensus definition of metabolic syndrome in children and adolescents, they had 42.3% of them had metabolic syndrome. And we observed that higher body mass index and presence of hirsutism are associated with high risk of metabolic syndrome in our patients. If we consider the lean PCOS patients, the lean PCOS patients are also have higher risk of getting higher BP, dysglycemia, dyslipidemia, and also metabolic syndrome. Among the lean patients, 14.8% of the PCOS patients, adult patients, had metabolic syndrome. So we can't exclude the lean patients from the risk of future cardiovascular risk. So if we summarize the cardiometabolic risk factors in PCOS, there are some traditional risk factors of polycystic ovary syndrome, like central obesity, dyslipidemia, hypertension, impaired glucose tolerance, and all have been found higher in women with polycystic ovary syndrome, even after matching with their body mass index. And there are some conventional risk factors that have included hyperandrogenism, sympathetic nervous system dysfunction, chronic inflammation, oxidative stress, hemostasis, and fibrinolysis disturbances, vitamin D deficiency, though I have not discussed this issue in this today's talk. There are also mood disorders associated with PCOS, gut microbiota dysbiosis, and epigenetic alterations. And all these may lead to premature atherosclerosis, which has been evident by endothelial dysfunction, intima media thickness, and coronary artery calcification by various studies I have already demonstrated. And all these culminate in non-alcoholic fatty liver disease, type 2 diabetes mellitus, coronary heart disease, and stroke. So what are the guidelines for screening and managing cardiovascular risk factors in PCOS? Current guideline highlights on these issues. The weight and BMI should be monitored at each visit or at least twice a year. The frequency should depend on and it should be agreed upon with the patient. The frequency may be more frequent if there is higher risk, cardiovascular risk. And glucose monitoring should be done for at least 3 years by fasting plasma glucose or hemoglobin A1c. And if patients with PCOS have other diabetes risk factors like hypertension, like strong family history of diabetes, oral glucose tolerance test should be done at every 1 to 3 years. And during preconceptional stage, or when a woman with PCOS comes with the problems of fertility advice, a oral glucose tolerance test should be done. And if it is not done at the time, this should be done at the earlier pregnancy and obviously at 24 to 28 weeks of gestation, as they have very high risk of gestational diabetes mellitus. And blood pressure should be checked annually. And lipid screening is should be done, especially in overweight and obese women at the diagnosis. And the lipid measurement should be repeated based on the risk factors. And another thing is that obstructive sleep apnea, which also confers high metabolic risk, the diagnosis should be considered based on the symptoms of the patient and treated only if symptomatic. But what the actual scenario we do? This is a fantastic observations from our Indian colleagues. They have found that even the endocrinologist, the weighted percent value for screening dysglycemia was only 70%, and lipid profile for it is much less, only 45%. So we can say that in our setting, we are leaving many of our PCOS patients unscreened for diabetes and for lipid profile. I think the scenario is also appropriate for our country and our neighboring countries. So as a whole, PCOS management should be patient-centered, starting from the lifestyle plan and support, and metabolic screening and intervention should be an integral part of polycystic ovary management. And the goals of PCOS management must be directed to the prevention of long-term complications of polycystic ovarian syndrome, majority of them which are metabolic complications. Evidence-based summaries recommendations have been provided by various authorities, and the last one is updated in 2018 that has been endorsed by Monash University. And these have clearly identified some problems and clearly advocated some issues to address and to handle the metabolic issues in patients with polycystic ovary syndrome. And they say that always the policy or the management that should be patient-centered and should be directed upon the need of the patient. There is no specific diet type that is suitable for polycystic ovary syndrome. The general healthy eating principles should be advocated for patients with PCOS and must be tailored according to their custom, according to their body weight, and according to their habit. Regarding exercise, the exercise recommendation for polycystic ovary syndrome is almost similar that is recommended for type 2 diabetes mellitus also, and also for the healthy population. The obesity and weight management must be done, prioritized in patients with PCOS to reduce the risk of cardiometabolic risk. Lifestyle modification practice has enormous effect on the especially the weight and also the metabolic profile. This is a meta-analysis that found no significant difference in the improvement in the menstrual cycles between the lifestyle management and metformin alone, and between the lifestyle management plus metformin and metformin alone. So lifestyle management should be cornerstone for preventing the metabolic complications of polycystic ovarian syndrome. The pregnancy rates and body mass indices are not significantly different between the lifestyle management and metformin group. And lifestyle management reduced the insulin resistance and increased serum levels of sex hormone binding globulin compared to metformin. So these meta-analysis found a lifestyle management superior compared to the metformin in terms of menstrual cycles, pregnancy rates, body mass indices, insulin resistance, and sex hormone binding globulins. This is another meta-analysis showing the effect of metformin on polycystic ovary syndrome in overweight women. The intervention group with metformin had significant difference with the control group in changes in body mass index and waist circumference. Overweight women with polycystic ovary syndrome treated with metformin had significantly improved endocrine and metabolic indicators measured as testosterone, FSH, LH, and LDL cholesterol. However, metformin did not regulate the secretion indexes of fasting insulin, HOMA-IR, sex hormone binding globulin, HDL cholesterol, total cholesterol, triglyceride, fasting blood glucose, and androstenedione. So some parameters are improved with some endocrine and metabolic parameters are improved in the metformin group compared to the placebo group. This is another review article that summarizes the effect of various modalities of treatment in PCOS on impaired glucose tolerance and impaired fasting glucose. I have already told the effect of metformin. Thiazolidinediones also found effective for reversion from IGT to normal glucose tolerance, and SGLT2 inhibitor had neutral effect. Recently, GLP-1 receptor agonists are getting more importance and being tested as in several randomized control trial to find their efficacy in terms of weight management and also reversal of dysglycemia in PCOS patients. And some small-scale studies also have shown the efficacy of inositol in this regard. Though DPP, one study, saxagliptin in combination with metformin have improved outcome in terms of dysglycemia. This is another meta-analysis that shown the effect of statin. We know that currently statins are not indicated as a primary prophylaxis of cardiovascular events in polycystic ovarian syndrome, and the use of statin in patients with polycystic ovary syndrome is not clear-cut demonstrated by various guidelines. This meta-analysis shown that trials comparing statin with placebo, statin monotherapy reduced LDL cholesterol, triglyceride, and total cholesterol, and 4 trials comparing statin and metformin with metformin alone shown that the combination of statin and metformin decreased the level of inflammatory marker, that is CRP, triglyceride, total cholesterol, and LDL cholesterol. And combination therapy fails to reduce the fasting insulin, HOMA-IR, and total testosterone. We should consider that these trials are all short duration, so the long-term effect of a statin on the cardiovascular markers and also the cardiovascular outcomes with statin are not clearly defined still now. So we should consider the polycystic ovary syndrome as a lifelong disease which changes the woman's health paradigm from adolescence to the peri and postmenopause, which starts as a reproductive disorder and ultimately ends as a metabolic disorder. So we can say what is known, the elevation of surrogate biomarkers of cardiovascular disease occurs in polycystic ovary syndrome. This is clearly demonstrated by several observational studies and also evident by several meta-analyses and systematic reviews. But still unknown is that what extent and magnitude the elevation precipitates more frequent and earlier events of cardiovascular disease like stroke and myocardial infarction. This is not known, probably because of lack of long-term follow-up study on women with PCOS. As PCOS occurs as an earlier age, and if we do not follow this patient till the end of life, we can't conclude or make a conclusion on the clinical outcome of the high surrogate biomarkers of cardiovascular disease in women with polycystic ovary syndrome. So I am at the end of my presentation. So if I want to summarize the all things, PCOS, I can say from an endocrinologist point of view, this is finally a metabolic disease which starts as a reproductive and cosmetic problems, and metabolic complications are present not only in overweight and obese patients with PCOS, these are present in lean patients with PCOS also. And Current management of PCOS focus primarily on the short-term cosmetic and reproductive consequences, but the metabolic and psychological risk factors are often not considered while management, especially in the setting where endocrinologists are not involved. And we should consider early screening and close follow-up. These are required for we should encourage the both groups of patients, that is lean and obese patients with PCOS. We should consider the early screening and follow-up that has been recommended by various guidelines. And thank you all. This is the month of month of independence of Bangladesh, and I gratefully remember the contribution of India and their army and population in our independence. And this, we are celebrating also the birth anniversary of our father of nation, Bangabandhu Sheikh Mujibur Rahman.